up the GI and the anti-infectives in different mini lectures, so it's easier for you to focus and learn. For this 20 minutes, I will be focusing on endocrine drugs and especially anti-diabetic drugs. So if you go back and remember your pathophysiology regarding insulin, I think it's really important to remember the pathophysiology behind insulin secretion and its lack of secretion and the types of diabetes in our population. So, in broadly, we think about anti-diabetic drugs. If we look at the name diabetes, that is the pathophysiology, right? So, from pathophysiological angle, diabetes can be type 1 and type 2, and both are related to insulin. So if you go further back into your A&P and try to remember who secretes the insulin and what is insulin. So insulin is a protein/hormone that's secreted by the beta cells of islet of Langerhans, which is kind of like an island, the pancreas is almost like an island, and then you have beta cells which secrete insulin and glucagon. So the work of insulin is to store the blood sugar and then release it when needed for energy, right? So insulin is very important in terms of giving energy to the body by breaking down glucose. On the other hand, glucagon is important to store it in the form of a higher level of carbohydrate, or not as glucose by itself, but in the form of starch in the other areas. So insulin becomes a very important hormone to make sure we get the energy in our bodies. So in order for this insulin to function, there are several organs that is important. It's closely working with the liver, because the liver helps in glucose production, metabolism, and also it works with the small intestine because that's where absorption takes place. And in addition to that, the muscle also plays an important role because it also helps in storing, glucose in the muscles in form of for producing energy if needed at a later time. So with that being said, in some conditions, for example, genetic positions or a change in the microbiome, that's a new word for you, but you don't have to know that, in changes in the metabolic syndrome, we call it. There's inflammation in the body due to various reasons. Could be genetics, could be environmental reasons, or could be diet related, lifestyle related, extreme metabolic stress, where there could be inflammation, and this inflammation can cause destruction of the beta cells which produce the insulin. So this is the background for in general of diabetes. So when there's either destruction of the beta cells, like in type 1 diabetes, or when there is a resistance of the insulin on the cells, meaning the cells are resisting the insulin from entering it, so thereby there's excess sugar in the blood. You see there's two differences, right? There's differences between type 1 and type 2. So in type 1, there's lack of production. In type 2 diabetes, there's insulin resistance, where there's resistance to the insulin itself from the cellular level, that the body is not able to utilize the insulin. Thereby, there's increased presence of insulin in the blood. So when there's increased presence of sugar in the blood, so diabetes is increased presence of sugar in the blood, right? So that is called hyperglycemia. So when a patient has hyperglycemia, they could have micro and macrovascular changes. So microvascular meaning like small changes in the smaller type of cells, or the smaller organs, if you want to call, like in the skin, like in the foot, in the retina of the eyes, where they get diabetic retinopathy, and then neuropathy in the nerves, right? And there could also be macrovascular changes, meaning changes in the heart, because of, patients with diabetes are high risk for MI. So those are macrovascular changes. Again, these are all pathophysiology. The reason I'm trying to review these for you is for you to be able to understand what is really happening in the body when there is diabetes. So diabetes is decreased or no production of insulin, which leads to hyperglycemia, that is excess sugar lying in the blood, which causes microvascular changes. There's also another type of diabetes called gestational diabetes. Patients who have diabetes during pregnancy are at risk for developing type 2 diabetes later in their life. So, again, you could call these a group of diseases from this handout. And the symptoms of hyperglycemia include excess thirst, excess hunger, excess urination. So it's polyuria, polyphagia, and polydipsia. If you look at that, there's also weight loss if in severe cases. Initially, there's weight gain. It's not because of diabetes, but weight gain can be, and obesity can be risk factors for diabetes. But once diabetes is not diagnosed and people continue to not know, many times that's what happens, especially in type 1. They don't know until like their blood sugars go up to like 300 or 400 and they come to the hospital with diabetic ketoacidosis. So weight loss is usually late stage when there's muscle wasting. With that being said, I would like to touch a little bit on the diagnostic tests that's important for you to know from the angle of diabetes. The gold standard test is hemoglobin A1C. So any number about 6.4 percentage of HbA1c, that's hemoglobin A1c, is diagnosed. The patient is diagnosed with diabetes. That's a gold standard, right? However, when a patient shows a fasting blood sugar of 126 milligrams per dl, meaning a client fasts for about 12 hours, and then they do a fasting blood sugar in the morning, and if it's 126 or above, it's that they're diagnosed with. It's one of the criteria, but the gold standard is H1B1, hemoglobin A1C, which is usually done in the clinic when there's suspicion for long time diabetes undetected, or also to follow up regularly once they have pre-diabetes. So when a patient has anything above 100 fasting, they are called pre-diabetic. So at that time, it's really important to stress the importance of diet, lifestyle changes before placing them on any pharmacological intervention, which include these drugs and insulin, which we will be talking about. So in general, it's really important for you to know the signs and symptoms of hyperglycemia and hypoglycemia, and then what could happen when a patient takes any of these drugs or if they take insulin in terms of their signs and symptoms, because many times these side effects would be related either directly to the medication and where it affects, or it could be related to hypo or hyperglycemia. I hope that makes sense. I think this is where many times in exams you might be having trouble in your first semester when you have to apply thinking. So critical thinking and clinical judgment comes with practice and you trying to think like a nurse. So with that being said, I hope I've laid a good foundation for you to understand pathophysiology of diabetes, but you can always go back and look at your pathophys notes. You could look at your there's so many online resources available to understand the pathophysiology and how insulin works on the body, and the way people are diagnosed and what are macrovascular changes, etc. Right? Even though these would not be direct questions for exams from the pathophysiology, without understanding these and not knowing these, it'll be hard for you to answer some of the questions. So with that being said, I would like to bring to your attention these 5 drugs. So the bigonides, sulfonylureas, thiazolidines, alpha glucosidase inhibitors, dipeptidyl peptidases. So these are the 5 classes of anti-diabetic drugs. In addition to this, there's insulin. Insulin can be given, at least for now, only through a sub-Q or IV. It cannot be given a oral form, right? So keeping that in mind, first I want to review these oral diabetic drugs. So the very first class of drugs that was ever found by scientists was the sulfonylureas. If you look at that sulfonylurea category, that is the most, oldest drug. Before we venture further, I want you to take a look at the mechanism of action of each of these drugs and where they act. So if you look at the sulfonylurea, in your med table, it tells you that it stimulates insulin secretion and improves insulin sensitivity. So if you look back in those days, the only thing that people knew was that there's some type of insulin resistance. So they needed to decrease the resistance, right? So that's what the scientists discovered then, right? But since then, there are other drugs targeting different parts of the insulin activity system, if you want to call. So, meaning some drugs target the small intestine, for example, the alpha glucosidase target the small intestine, and then the biogonides target a few areas, the liver, and then directly to decrease uptake of glucose itself, right? And then if you look at the thiazolidines, they target the liver. So if you remember a few minutes back, I talked to you about different parts of the body where insulin, works and how the glucose metabolism happens through the liver, through the small intestine, and through the muscle too, right? So the scientists have started exploring different ways in making these drugs more effective. So first, let's talk about sulfonylureas. So if you look at their names, they end with the rides or the sides: glyburide, glipizide, glymeride, glimepiride. So when you see a drug with those IIDE, you know it's a sulfonylurea, and they work by stimulating insulin secretion. So think about it this way. You cannot give this to type 1 diabetes where they do not produce any insulin, right? But you could give this drug to a type 2 diabetic where they produce some insulin, but it's not enough. So they try to increase the stimulation of insulin and also improve sensitivity to the insulin in the tissues. So that thereby the tissues and the cells are more accepting and they're not resisting the insulin. If you think about these two mechanisms of action, that already tells you why a patient could be risk for hypoglycemia. It could reduce sugar levels, right? When a patient is you give someone that's taking that's not who's not producing insulin, right, and then you give them a medication to stimulate insulin. Now there's going to be more insulin, and you're doing it from outside the body, which makes the patient risk for hypoglycemia. So with this drug, there's risk for hypoglycemia because there's direct action on insulin. I hope you get this. So this is where students sometimes get stuck when I ask a question like, which drug is more risk for hypoglycemia. If you do not understand this background why, it might be hard for you to choose which drug. I hope you understand this part. So the next class of drug and the most common and the latest, the best drug is the class called biogonides. So the biogonides, one example is the glucophage or metformin. So metformin is a drug that's very, very common used these days, and this is the first line of drug given to type 2 diabetes. Again, type 1 diabetes can only be treated with insulin. So with this metformin, there are few important things to keep in mind. You will be asked a lot of questions on this drug, so please pay attention. Try to really get this well. So the way it works is by decreasing the production of glucose by the liver. See, it's working on the liver, right? And it also decreases uptake of glucose by tissues indirectly. You see that? So these are all indirect action, and they also decrease intestinal absorption. So more recently, scientists have become even very up to date by trying to identify ways in which drugs can act without causing hypoglycemia, like in sulfonylureas. So some of the side effects, though, with this type of drug, that's the metformin, is that they can cause some GI side effects because you're targeting the intestine. They can also cause something called lactic acidosis. Even though it's very rare, it could be fatal, but they are rare. When patients have any type of kidney problem, there could be buildup of this drug metformin in the body and thereby causing lactic acidosis. So that's really important to know. And some patients complain of metallic taste, not everybody, right? More than this, I really want you to think about this metformin in terms of the kidney, um, and what has been found in the past decade is that patients who take metformin and when they receive CT contrast dye, they are risk for kidney damage. So when a patient is receiving CT contrast with dye, it's really important to make sure the patient has not taken metformin at least in the past few days. I think it's 48 hours, I'm not sure. So you really want to make sure that they are not on metformin before or after at least 48 plus 48 minus hours to make sure that no kidney damage happens to this group of patients. Usually metformin is given about 500 to 1000 milligram twice a day, and it's well tolerated, and they do not have hypoglycemia like in sulfonylurea. So just please pay attention to that. So these two are the most important class of drugs. The other classes are quite newer, and you will not be tested as much on these classes compared to the bigonides or the sulfonylureas or the insulin. Insulin is a really important thing to know. So now let's talk about this class of drugs called the thiazolonidones, right? The thiazolonidones are a group of drugs that decrease insulin resistance and they inhibit glucose production. Again, they target the liver. So these drugs have shown good effects in managing blood sugar. They again do not cause hypoglycemia, but they do have hepatic toxicity. Some cases have also reported cardiac problems, like heart failure or liver damage to an extent that the patient had needed liver transplant. So there's a black box warning on these drugs. Hence, it's not as commonly used as metformin or even the sulfonylureas. So the names of these drugs are the pioglitazone or the rosiglitazone. So the glitazones are the suffixes for you to remember, and to know that there's black box warning, and to be cautious when patients have any type of liver damage, and or to watch them for their liver function. Right? When we say liver function, we are looking at liver function tests like the AST, ALT, alk-phos. Usually the bilirubin does not raise, but it's the AST, meaning it's the transaminases, which are the enzymes, ALT, alk-phos. These are all enzymes that are secreted by the liver that we need to watch to make sure that those numbers don't go higher. And then you have the alpha glucosidase inhibitors, which an example of this class of drug is acarbose. So the name gives it away, acarbose, right? It's preventing carbose, right? Inhibiting enzymes of the small intestine, delaying absorption of the glucose. So what it does is just delays the absorption of glucose in this main target is the small intestine, right? So with that being said, you already know the side effects could be GI problems, right? Excess gas formation, diarrhea, abdominal pain. So for this, I just want you to know where it acts and what are side effects. So acarbose, what class it is and where it acts and what are the side effects. The last but newer one is the sitagliptin or Januvia, which is commonly used these days, even compared to the thiazolone or the glitazones or the acarbose. I've seen this a lot in practice, sitagliptin. These are the dipeptidyl peptidase inhibitors. So what they do is they delay breakdown of incretin hormone. This is another hormone more recently found. I'm not going to expect you to know in detail about the incretin hormone, but just know that sitagliptin acts on the incretin hormone, and one side effect is the respiratory infection. So with that being said, I would like to switch gears and talk a little bit about insulin in general. So in general, insulin is given for patients to treat type 1 diabetes. That's the only choice of treatment, right? But insulin can be also given when patients with type 2 diabetes are not managed with any of these medications. That means their sugar levels are not being able to be managed with one or two of these medications. So, that being said, I will refer you to your book to make sure you understand, you know, the impact of the different types of insulin. That's the short acting, the regular insulin, the intermediate, and the long acting. Before I conclude, I want to bring one point for you to remember. So our body produces insulin at a steady state, meaning our pancreas secretes insulin constantly. That's called the basal, secretion, or the basal rate. In addition to that, when we eat something during a meal or a snack, during that time, the pancreas kicks in and produces boluses of insulin. So that's something really important to keep in mind. So when we give medications or when we give patients insulin, we try to mimic this, right? So when patients have type 1 or type 2 diabetic and they need insulin treatment regimen, it's important to keep in mind that a patient might need both the basal and the bolus, right? So basal meaning by standard they need to have, a set thing. That's usually the long acting. So the long acting, like the glargine or the Levemir that you see in your book, are long acting, meaning they act for 24 hours. So if a patient gets it one time at night, it's good for, till the next night. That's the basal dose. There's no peak onset, meaning like there's no peak. So these are basal, right? So we're trying to mimic close to what our body does in terms of producing this basal dose of insulin, meaning we need to keep that in our body all the time. In addition to that, when a patient has a meal, if they eat something, when our body produces boluses, right? For these patients, the insulin is not being produced. So we want to give them these short-acting insulin, like boluses, short boluses. That's when patients, when they have their meal, they'll take, insulin right after their meals. I would suggest that you really understand why we have to give the meal before we give the bolus. What is the risk here? Can a patient go hypoglycemic, and why? So this is something that sometimes students have trouble. So the risk for hypoglycemia with short acting is because of the peak, when it peaks, right? So let's say I gave a short acting insulin and it usually acts in 10 to 15 minutes. An example could be a Lispro. It's in your book. I really expect you to read those different types of insulin and their peak, especially because if you know the peak and the duration, it's easy to remember when can someone have hypoglycemia, right? And more importantly, it's important for you to understand what are the signs of hypoglycemia. And I want to conclude with this other thing, and we will continue our discussions and questions when we meet to know what are the symptoms and what do you do for hypoglycemia. Let me give you an example. You have a patient whose blood sugar was 200 and they have been ordered insulin. And you give them insulin. And then in another, 20 minutes, you find them a little confused, irritated, right? Signs of hypoglycemia will include cold, clammy, irritated, right? Sweaty. So you find them and they're a little confused too. But they're talking to you, they're a little off. Would you give them orange juice, right? Something to make their sugar level come up, right? That's something important to keep in mind. That's an intervention you have to do when there's low sugar level, right? However, if the same patient is not conscious, what did you do for them? It's important to immediately give them something IV because they're not responsive, right? To immediately look at their levels, right? So to increase their levels of sugar, the glucose in the body, you would give them dextrose or glucagon. So dextrose or glucagon IV is the first choice when patients are not responsive and you know that their sugar level have dropped. Usually it's below 70, you treat it immediately, right? So normal sugar levels in the body fasting is 100. But if a patient's blood sugar is below 70, that's kind of like an emergency. You need to treat it right away before they become unresponsive. And the way to do it is to give something orally if they can, and if they cannot, if you think that they might choke, it's safest to do an IV or IM. So with that said, I hope you understood the basics of anti-diabetic drugs and managing care of patients when they are on anti-diabetic drugs from a basic perspective. You will not be asked questions on, higher levels like DKA or diabetic ketoacidosis. This is just the basics. I hope this was useful. We will meet soon later. Thank you so much.